Good evening and namaste everyone. On behalf of Intas Pharmaceutical Limited and Genetic Division, I welcome you all to this second episode of webinar series Endocrine Talks 2. And today we are having two interesting debates on osteoporosis and intermittent fasting. And we have a galaxy of faculty who are going to dissect this topic, which will help us in understanding in a better way. And to moderate this session, we are having with us our course director, Dr. Professor Subhankar Chaudhary sir. He is currently a head at the Department of Endocrinology at SSKM Hospital, Kolkata. So without further ado, I hand over the session to Dr. Chaudhary sir. Over to you, sir.
Thank you very much. Very good evening to all of you. It's good to have very good faculty with you all the time. And having a debate, of course, there are different purposes of having a debate. One is, of course, to find who is the winner, who is the loser. But eventually, for us, I'm sure we all agree that this is a forum to be abreast, to understand different points of view on different topics. And eventually, we have to, of course, form our own opinion. But we have called this one a debate with a difference, because whereas the individual protagonist or the antagonist are not allowed to speak their actual mind, they have to speak to the topic only. So we'll have final say in terms of overall what it means for us, what the usual practitioner can take home from these deliberations. So we have someone called a neutral voice. So so let me have the pleasure of introducing the first topic, which is osteoporosis has greater health implications than even type 2 diabetes. We all know about the enormous health implications of type 2 diabetes. Possibly we are getting to understand the implications of osteoporosis as well. And in order to give us a front seat view of all these issues, we have as the protagonist Professor Pramila Kalra, who is professor and head of endocrinology at the Ramaya Medical College and Hospital at Bangalore. And to oppose the motion, we have none other than the one and only Dr. Bansi Sabu, who is the immediate past president of our beloved society, RSSDI, and is, of course, the chairman of Diabetes Care and Hormone Clinic at Dia Care, Ahmedabad. To provide us with the neutral voice, we shall soon be joined by Professor Sanjay Vadada, who is currently the professor and head of the Department of Endocrinology at the prestigious PGI Chandigarh. So with these few words, let me call upon Professor Pramila Kalra, to speak in favor of the motion.
You're muted.
I'm just unmuting. Sorry. Thanks, sir, for the kind introduction. And I'll be just sharing my screen. So I hope my slides are visible. Are my slides visible?
Absolutely. Yeah. And you are audible.
Yes, thank you. So thanks for inviting me for this debate. I think as Dr. Subhankar sir has already told, that this is more of a viewpoint also we are trying to put forth and the actual facts. So I'll be putting through the actual facts in the next 10 minutes, and then we will have a discussion. So my topic is osteoporosis has greater health implications than even type 2. And I am speaking for the motion, that is for the topic. And I strongly feel that the answer is absolutely yes. So when we talk about osteoporosis, what is actually osteoporosis? We know that osteoporosis is basically a condition where there is a low bone mass, there is a microarchitectural deterioration of bone tissue, there is an increased susceptibility of fractures. So basically the main problem which comes up is that these patients are prone to fractures. They may be bedridden for a long period, and they are mostly older people. So we are not right in just saying that this is just a disease and we just have to think about fractures or susceptibility to fractures. because we know that it is not just an inevitable consequence of aging, but it is one of the very, very important diseases which needs to be considered. Now, if you talk or if you see the prevalence of osteoporosis and osteopenia in healthy Indian population, it's quite high. So this was a cross-sectional retrospective study where they had tried to see the prevalence of osteoporosis. And what they found that about 1.6 million hip fractures, they commented, that occur every year worldwide. And the incidence is definitely be more by the year 2050, that is when they are expecting around 6.3 million. And most of these, like more than 50% of all these osteoporotic hip fracture are actually going to happen in Asia. This is another alarming fact by the year 2050. And in India, if you see, there were around 26 million osteoporosis cases in 2003, while in 2013, 50 million people were either osteoporotic or had low bone mass. So very important to understand that an annual incidence rate of hip fractures of 163 and 121 per 100,000 per year in men and women and men, above the age of 55 has been reported in this study. So this is quite an alarming fact, which we know. Now let us see the epidemiology. This was a study where they have tried to see the lifetime risk in women, men, for hip fracture, for spine, for forearm. And you can clearly see here that the lifetime risk of hip fracture in women is to the tune of 23%, for spine is 29%, and wrist is around 21%. And men are not far behind. It's around 11% for hip, 14% for spine, and 5% for wrist. And the most alarming thing which we have to focus on is the hospitalization. What we are talking about is the health burden or the health implication. And you can clearly see that if a patient has a hip fracture, the hospitalization percentage is fully 100%. So 100% of them need to be hospitalized. Huge cost and huge morbidity and mortality for sure. So isn't it alarming? We know that osteoporosis affects lots of Indians. We have already seen the data. The most important thing to understand it mostly goes untreated and undiagnosed. The major problem is we think it's a small problem, but it's not a small problem. Many of the patients are not diagnosed. They come first time with osteoporotic fractures. They land up with fractures. They don't reach the hospital, and the actual numbers don't come into the picture. Problem is definitely going to be bigger. It's not going to be less at any point of time. India, with a bigger population, is one of the emerging economies we know, but also a very populated country. Life expectancy is going to increase. By 2025, we are expecting the life expectancy to increase to 71, and by 2050, it is going to be increased to 77 years. So those above the age of 50 will constitute around 22% of the population in 2025 and 33% of the population in 2050. So we can understand if osteoporosis is going to be prevalent in that population, where are we going to be? So the number of hip osteoporosis fracture in India are estimated to climb to 600,000 per year by 2020 and more than 1 million by the year 2050. Burden: 1 in 3 women and 1 in 5 men over the age of 50 will sustain an osteoporotic fracture. Substantial pain, suffering, disability, and even death. Burden not only on the individual, but also on the caregiver, the society. So this is the burden. We have to understand 1 in 3 women, 1 in 5 men. Alarming facts: 1 osteoporosis fracture is occurring every 3 seconds. So while we are having this talk, we can understand how many osteoporosis fractures have occurred. 6.3% of men over the age of 50 and 21.2% of women over the age of 50 are affected. Disability: women over the age of 45, we know that more time is spent in the hospital because of these fractures. 20 to 24% of them die in the first year after the hip fracture. They experience loss of independence. They are restricted for their activities. 40% of them are unable to walk independently, and 60% require assistance a year later. 33% are totally dependent on nursing care after a hip fracture. Longer hospital stay, more probability of dying, loss of independence. Isn't it a disability? Isn't it a problem? Another big issue is the knowledge gap. This is not diagnosed only. What we are seeing is only the tip of the iceberg. We don't know how many patients actually exist. And this study clearly showed that suboptimal knowledge is there among medical professionals regarding the aspects of diagnosis and management. So it is not diagnosed and hence not picked up also many times. So we are just seeing one tip and we don't know actually how big is the iceberg. So bigger picture, it is even a bigger threat. We already saw the data, 1 in 3 women above the age of 50 and 1 in 5 men will experience it. Economic burden, if you see, estimated around 37 billion euros. Previous and incident fractures will lead to lot of morbidity, lot of problems with the independence of the patient, and they get dependent on the caregiver or on the society. Costs are expected to increase by 25% in 2025. It's a very, very alarming fact. Global prevalence of osteoporosis, if you see, it was reported to be 23.1% with the prevalence of and in the men, if you see, it was around 11.7%. Indian data also, the prevalence of osteoporosis around 24.6% in men. And we know that in India is much higher, and 42.5% in women above the age of 50. So numbers are bigger than diabetes. Men are also not protected. Osteoporotic fractures in men are more common than MI and prostate cancer. And if you see, majority of the studies have a focus on women, but men are mostly not tested many a time, and they may just be missed from the picture. Lifetime risk is very, very high. If you see the lifetime risk for a wrist, hip, or a vertebral fracture is in the order of around 30 to 40%, even in developed countries, and very close to that for coronary artery disease. It's not only a major cause of fracture, but it also causes bedridden patients, makes them dependent, and later on they may develop complications. We know the loss of the daily days of adjusted life years, loss of the income, a lot of factors come into play. So huge economic burden, huge costs of health, and patients have to be dependent on others. They are not able to earn for themselves, and around 50, 55, once they develop these fractures, they may be in the hospital for long periods. So we know that it is associated with considerable healthcare costs and a higher burden of patients, especially if they have concomitant other chronic diseases like COPD, or if they have depression, or if they have other chronic diseases associated like diabetes also, they may have even higher morbidity and mortality. And mortality in older adults, if you see, we know that it is one of the major causes of mortality. In this study, we have seen that not only diabetes, it's osteoporosis also, which is one of the most important risk factor for all-cause mortality, and it was followed by diabetes. So if you see this, the hazard ratio was 4.46, and if you see for diabetes, it was 2.17. So osteoporosis was a major risk factor for all-cause mortality in this study. So to summarize, osteoporosis is definitely highly prevalent both in men and women. It's not only that women are affected. We have to understand that men are also affected. Only thing is they may not be tested, not be diagnosed. And whatever data we have the data that men are affected. Lifetime risk for fracture is very close to that for coronary artery disease. Loss of working years, loss of productive years, dependence. This is a very common problem after osteoporotic fractures. Osteoporotic fractures in men are more common than myocardial infarction and prostate cancer, significantly associated with higher morbidity as well as mortality because they get bedridden, they are dependent on others, and that may lead to even more infections and multiple problems. We see so many older patients coming with bed sores once they are bedridden. They are not taken care of, and a lot of problems, and economic burden is definitely huge. There's no controversy on that. So I conclude by saying that it's clear that osteoporosis has greater health implications than even diabetes. Thank you.
Thank you, Pramila. That was a strong, there were several strong points to suggest the seriousness of osteoporosis. Primarily, of course, because of the risk of fractures and the morbidity and mortality that entails, and of course, almost 100% need for hospitalization following a hip fracture. So we'll have the sort of the contrary view in comparing osteoporosis to type 2 diabetes. So we have Dr. Bansi Sabu, to convince us no, osteoporosis is important, and none of us would disagree, but type 2 diabetes has greater health implications in our country or across the world. Over to you, Bansi.
Yes, first of all, thanks, sir. Thank you for invitation. I agree with Pramila that it's a major problem. I don't deny for that, whatever the facts which she had talked, that morbidity and mortality with osteoporosis is high. But the debate which is given to me is not comparing to disease, but here we are understanding and trying to talk that it's which is having a bigger health problem. It does not mean that the osteoporosis or diabetes, if we say that whichever is the bigger problem, the other should not be taken care. So let me share with my slide. And once again, thank you. My slides are visible, sir?
Yes,
Yes,
sir.
sir,
Please,
Yes.
just go to slideshow mode.
So I'm already in slideshow mode. Is it?
Yeah, now we can see. Yeah, it's absolutely fine.
So I'll be talking that I disagree that the health implication point of view, probably the type 2 diabetes have a greater health implication in compared to the osteoporosis. I'm sure all of you have seen this slide multiple times. This is IDF Atlas 2021, just to tell that the number of persons with diabetes all over the world are very high, and it is increasing. And it is increasing like anything. That is what the data which I just trying to show, and I'm sure everyone knows about it. The point is here that 10.5% of world population in the age group of. Now we know that the osteoporosis is a disease which already Pramila had talked that it is a disease of 50 or 60 or above 60, or those who are suffering from osteoporotic fracture, and the morbidity and mortality, what she was talking of, are the more elderly people. While the disease of diabetes, which occurs even in 20, 30, and 40. So if you see the health implication, the person who is developing the diabetes in his 20 and 30, and he will survive for another 50 years or 70 years or 60 years. So the health implication over the society is very high. If somebody develops the osteoporosis at the age of 60, 65, 70, 75, the survival period may be another 10 years or 5 years or 20 years. So the health implication of that may be probably less. I don't deny that it is not a serious disease, but the point is here, the world population is almost 10.5% of the world population. They have diabetes, and that range from 20 to 79 years of this. And even it is not plateau, still the rising problem. The similar is the osteoporosis incidence and data also we see it is rising, but not the way it is the rising in form of diabetes. Diabetes is rising much higher. Diabetes is 3 to 6 times more common among Asian Indians. So if I consider the India, the health complications or health implications of diabetes, it is again very high in compared to the Western population. In compared to the world, we are the one, we and China are having highest number of people who have diabetes. We have developed diabetes even almost 2 decades earlier and 10 or 15 years earlier than the Western population. We are developing diabetes even at the BMI which is less, with the 23 or 22. So we are not, I mean, only the obesity induced diabetes is not like with the BMI of 30 or 32, only we are developing diabetes. And the very important point, we develop not only diabetes, but we have 2 to 4 times higher mortality, which is in compared to the Western population or to the even Chinese diabetics too. So this early impact, early onset of type 2 diabetes, this impact very high. The extensive impact of this early onset type 2 diabetes, it is heightened risk of the premature development of microvascular and macrovascular complication, in addition to psychological morbidity during their working life. So if somebody develops diabetes in 20s and 30s, the chances of developing complications will be in 50s or 60s only. So, you know, the complications and the psychological morbidity during his working life is very, very high. And that is very important as far as health implications is concerned, because you are dealing with this young and who are very, working in their lifetime, it is between 20 to 60 years. The cardiovascular risk markers are often present even at the time of onset of type 2 diabetes. So those who are having diabetes, probably they 2/3 of them, they develop heart disease or the cardiovascular complication maybe in another 15 years or 10 years. And the renal dysfunction, it manifests approximately 10 years after the diagnosis of early onset type 2 diabetes, and mostly those patients who develop the nephropathy in 20 years, they develop the end-stage renal disease. So again, the health implication of those patients, even they develop in their 40s, by 60s or 70, they have already the renal failure or end-stage renal failure. They require renal replacement therapy. So again, the health implications of these complications is also very high. The severe retinopathy, which is again a very major complication, and which what we see in a very significantly higher in young adults. Those who are developing type 1 diabetes, they develop even their retinopathy maybe in their 30s or 40. But those who develop type 2 diabetes, maybe in 60, again they develop severe retinopathy, and that could be again a big health implication and health complication for that. In their 40s, many of them have cardiovascular risk corresponding to they are in their age of 70. So this is what we have. Those patients who have diabetes in their young population. But if you see the osteoporosis prevalence, the WHO definition of osteoporosis, the disease affects 6.3% male over the age of 50 and 21.2% of the women over the same age range globally. If I take it 50 years of the age, but if I take it 60, 70, 80, I fully agree that yes, number of persons will be very, very high. But in compared to that, the 50 or 60, there will not be many. And this is the IUF data, and which is what World Health Organization is also talking about it. This is the paper which is prevalence of osteoporosis and osteopenia in apparently healthy Indian population, a cross-sectional retrospective data where Sujit Jha and some of the doctors from Delhi who had published this. And this you can see that disease is prevalent only in the age which is above the age of 70, mainly with the more than 1/3, but otherwise in the more in the female. In male it is still 5.6, while in the female it is between 60 to 69, it is 18.6, but again in the male it is 4.3. The data which I had shown of the world, while in India the data is 50 to 59, for male it is 0.5%. That was the data which is being published from India in 2018. If you see again this WHO unpublished data, this is extract where we had seen that burden of disease, which is estimated as a disability adjusted life year in 2002 in America and Europe combined. This is the Western data where we had talked about the diabetes, and this is 2002. So I mean in 2022, in last 20 years, we could not find any newer data for this from the World Health Organization, but this is the osteoporotic fracture, and in compared to you see the diabetes mellitus, where we are as far as osteoporotic fracture and diabetes mellitus. This is the disability adjusted life years, and these are the patients who have osteoporotic fracture which is above the age of 65, where they had seen this, while diabetes mellitus they had seen the patients who are above the age of 60, what is the incidence and the prevalence of the diabetes and the burden of disease, what they have with them. So the diabetes is not just simple glucose disorder. We can't just say that diabetes is a minor issue, but because diabetes comes with so many complications. A person with diabetes is going to develop micro and macrovascular complications. He is going to have a stroke. If he develops the stroke and he survives for another 10 or 15 years, his disability, his quality of life and his health implications to the nation is very, very high. If somebody develops heart disease, myocardial infarction, heart failure, and again he's going to survive for another 15, 20 years, you can see the health implication. Persons develop retinopathy, the cost of therapy, and then he's going to survive for another 20, 30 years with the condition with nephropathy, end-stage kidney disease, renal failure, renal replacement therapy, and all those patients who are having CKD, those requiring renal replacement therapy, either transplant or dialysis, 50% of them are diabetes. Even the neuropathy, diabetic foot, it is one of the, after the trauma, I think the biggest reason for someone to lose the limb is because of diabetes. So it is not just a simple glucose disorder, it is multiple complication, and we have to understand the health implication of diabetes and its complication. It's just not a simple glucose disorder what we are talking of. Diabetes is a complicated interplay of multiple pathophysiological abnormalities. It is not just, as I told you, it's a diabetes, it is a heart disease, it is a CKD, and that is what we are dealing with it. Not only that, many of our patients with diabetes also develop the chronic liver disease. Probably now we are talking that in next decade, it's a disease of diabetes is a disease of liver disease. Many of our patients who develop NAFL, they develop NASH. they develop even chronic liver failure or chronic liver disease also, and they need also the liver transplant too. 1 in 3 patients with diabetes have heart disease. They have also increased risk of heart failure. They have 60 to 80% greater probability of CV death and all-cause mortality. Those patients who have type 2 diabetes and established heart disease. 17 to 21% of the patient with CKD also have heart failure. They also have CKD in patient with heart failure, increases the risk of mortality by 25 to 30%. So diabetes affects almost every major organ of our body. There is a big impact on mortality. So the big impact on mortality, from approximately 1/3 of all deaths from diabetes occur in people who are working age. And this is very important. It is less than 60 years of the age. And that's the reason it is a big impact, big health impact on the society. It is approximately 6.7 million adults, which is between the age which I have taken from 20 to 79, are estimated to have died as a result of diabetes or its complication in 2021. And this we have taken from IDF Atlas 10th edition, which is published in 2021. This corresponds to 12.2% of global death from all causes in this age group. A person dies every 6 seconds from this disease, and this is a international data. So if I take only from India, probably one person might be dying every 3 seconds from other disease, as the prevalence is very high, as the complications are very high. This is the data which is talking from all over the world, where the Western data is also included. So you can see how a health impact, or how it is bigger health impact for our society. Diabetes itself is associated with increased risk of fracture, increased risk of osteoporosis, and even beyond osteoporosis. Despite increased bone mineral density in patients with type 2 diabetes, the risk of is increased due to the inferior quality of bone. Type 2 diabetes is associated with increased risk of hip fracture, a higher risk of fall and resulting fracture because of neuropathy, because of retinopathy, because of cataract. In patients with coexisting sensory motor neuropathy and diabetic foot, again balance disorders are problem, and insulin therapy itself is associated with increased falls, maybe because of hypoglycemia or hypoglycemic episode. It is preventable. That we know that diabetes can be preventable. Similarly, if we work for osteoporosis in a younger age population and they all are non-communicable disease, both can be at least prevented or can be delayed also significantly if it is worked in an early age group. So diabetes is one of the fastest growing global health emergency of 21st century, and this is what we all know, and I'm sure we all know about it, and we all are working for it. So to summarize my talk, diabetes is highly prevalent. Diabetes associated with multiple complications. Diabetes leads to greater impact on health status as far as its morbidity and mortality is concerned. It is significantly higher morbidities and mortality despite of excluding pre-diabetes conditions. So we are not here including the people who are having pre-diabetes or with insulin resistance or metabolic syndrome. Diabetes clearly produce greater health implication than osteoporosis. With this, I thank to Dr. Shubhankar and to Intaz for giving me this opportunity. Thank you very much.
Thank you very much. Things are getting quite hot in this maybe spring evening, and we will give Pramila a chance to maybe rebut
Absolutely.
Dr. Bansi
Thank you,
Sabu.
sir. Yes.
And in the meantime, we are happy to welcome in our midst Professor Sanjay Varada, who has the Department of Endocrinology at PGI Chandigarh, who has joined, I'd seen. Over to you, Pramila. Couple of
Thank you,
minutes
sir.
if you need it.
Sure, sir. I need it, sir. Thank you, sir.
Okay.
So with due respect to my opponent started by saying that diabetes is a pandemic. We are not negating the fact that diabetes is a pandemic, but what we are telling is osteoporosis is an upcoming pandemic, which is defeating diabetes as the pandemic and has greater health implications. He showed us a data of 2002. I would have been happy if he would have shown us the recent data where they have clearly shown that osteoporosis is also associated with more disability adjusted life years as compared to diabetes. Another thing he has said that clearly that we are targeting young population. He's always talking about young people, but he's not bothered about above 50. And he has to understand that the life expectancy in India is going to increase, and it is increasing. It is going to be 77 years by the year 2050. So we are going to have this so-called old population who is going to be the young population and who is going to be working. And we have to understand all our leaders are still young. And if we say that we can have osteoporosis, they can develop fractures, we don't bother. It's not right. We know that is still a productive population. So that part. And the other thing he has told that whenever a patient has patient has diabetes, they can get osteoporosis. So I think what he has clearly told is osteoporosis is definitely has higher health implications. If it is combined with diabetes, it may have even higher health implications. So I think that is what I have inferred from his discussion. So finally, I would just like to say that the prevalence also in India is quite higher. What he has shown in men, the prevalence, that is not the right prevalence. What we have seen in the recent studies, it has been to the tune of up to 24.6% in men over the age of 50 and 42% in women over the age of 50. So we know that prevalence of osteoporosis is even higher in India than what we see in the Western population, and we have reasons for that. So I would still like to say that osteoporosis has more health implications. It is an upcoming pandemic, and we have to look for treating it.
Thank you.
I'm not denying the fact that, osteoporosis is not a major problem. And I am not saying that the old person let them die because of the fracture and let them die because of the osteoporosis. I never told that. The data which I had shown of 2002 of WHO, unluckily we could not get the data of 2022. What Pramila is talking that in future it is going to increase, and I agree that it is going to increase. All the diseases are increasing, the increasing burden of the life. I mean, increasing burden of all this diabetes and osteoporosis. What my major point is, diabetes as it is developing in early age, and a lot of complications are there. Those who have already in their 50s.
Absolutely.
And that's the reason the health implications are higher. That does not mean that osteoporosis is less in compared to diabetes. It may be higher in patients who have already above the age of 60 or 70. But the point is here, the diabetes is developing in 20, 30, 40, and they develop a lot of complications. So the health implications of diabetes are much higher. As people are going to live for 77, you are saying even 80 or 85, those who will develop in diabetes in 20, if they are going to live up to 80 and 84, many of them are going to have a lot of complications. So that's the reason the health implications will be overall high.
Absolutely. Absolutely.
That's what my point is. But I'm not negating the fact whatever the Premier is talking. Yes, Sanjay. You.
Yes. So, it's the other part of the fact of life is people may not have only diabetes or only osteoporosis. They can jolly well have both of these. And we have got interesting questions in our chat box related to that. But before that, let Dr. Sanjay Vadara tell us his take on this topic.
Thank you, sir. Thank you, sir, for asking me about this. And so osteoporosis is my first love. Of course, I have weakness for osteoporosis, and I can see they both presented their views with very confidently and with lot of data. One thing I would like to say, maybe Dr. Pramila is worried about the osteoporosis and Dr. Bansi is worried about diabetes more, because Bansi is having a lot of money, more risk for diabetes. Dr. Pramila is being female, the osteoporosis is much more common. There's no doubt about that. But you think, and other thing is, sir, it is really difficult to compare the apple versus orange, something like that, because both the diseases are actually silent. Both the diseases are present with the complication. And when we talk about a complication, say diabetes complication as a cardiovascular involvement, there is significant increased mortality. For the osteoporosis, if we talk about hip fracture, then the mortality is very, very high, maybe around 30 to 40% in first year. So both are having definitely an increased morbidity as well as mortality. Like in osteoporotic hip fracture, there is a significant number of persons are unable to do their activity of daily life. So of course, both are important. But one thing here is what Dr. Shubhankar sir was telling is that because both are polygenic disease, both are chronic disease, and both can coexist. But Dr. Bansi has a little edge over here, because there are a lot of studies are coming that diabetes can affect the bone health very badly. as compared to like any other organ. But similarly, the osteoporosis may not be having that significant diabetes issue. So, of course, both are important. And so my view is that you have to take care of both of the things rather than only osteoporosis is important or diabetes is only important, and we have to control both the things. But maybe diabetes control is more important to prevent the osteoporosis related to the bone health. So this is my take.
Right. Yeah. And so it's very important because both the speakers and also Dr. Sanjay Vadada stressed on the fact that they are relatively asymptomatic before they lead to complications. So it's very important that we try and identify them early, and even better to prevent them. And again, lifestyle, nutrition, calcium, all these factors from very early on. Osteoporosis, we say, is a disease of old age. I think if we really want to build our bones for society, the attempt should start from very early on in life. So we'll quickly go to the questions chat box. So one is Dr. Sharma has asked, how frequent we should screen for osteoporosis in those with diabetes? BMD is not a reliable marker in type 2 diabetes. So which test do you recommend in patients with type 2 diabetes? So Pramila, would you like to take this, or shall we leave it to Sanjay?
Yes, sir. Sir, like diabetes, the first thing is we have to understand that whenever we are thinking about osteoporosis, first of all, we have to see that the patient's vitamin D and levels should also be checked. So we normally what we do is there is a guideline, like we obviously check after the age of 65, we have to check for all women. But before that, if we have a woman who is coming to us and we are suspecting osteoporosis, we have to see the vitamin D levels, we have to see the calcium levels, and we have to rule out any other reason. Like it has to be a proper evaluation. Like we start for an osteoporosis patient, we have to see that there is no secondary cause. So it's not that every woman or every man who comes to us with diabetes, we have to evaluate or we have to check for osteoporosis. But it's the thing is that after the age of 65, yes. Before that, if we have a reason, if patient had an osteoporotic fracture, or if the patient has any suspicion, like we are suspecting an osteoporotic fracture, or there is something which makes us suspect that this patient needs evaluation, we have to do. So and we have to see that the vitamin D intake is vitamin D levels are checked. We have to see the calcium. We have to rule out any secondary cause, like many of them may be primary hyperpara. We have to rule out many times multiple myeloma. They may come with all sorts of picture, and thyrotoxicosis. These are many other things which may be secondary causes of osteoporosis, which also commonly sometimes present with the problems like primary hyperpara can come with fractures. Even multiple myeloma can come with like many other manifestations, including they may come with hypercalcemia. So all these things, once we have ruled out, we have to decide about evaluating a younger patient. But as osteoporotic fracture is one indication where we have to do the testing at the outset, like even at an early age for the thing, but we have to see for other causes. So thyroid functions, calcium, vitamin D, rule out any secondary cause.
Yeah, so that will apply for any other individual as well, I suppose. Not only those with diabetes.
Yes, sir.
Yeah, right. Okay, so Sanjay, so the other part was, how do you assess osteoporosis in diabetes? Is BMD? So where do we look at the cutoffs of BMD? Do we use it differently, different cutoffs?
Sir, you are muted. Sanjay, unmute yourself.
So recent guideline says that one is we can take help of FRAX, and we can look for the long bone fragility fracture risk as well as spine fragility fracture risk. Second is that now they recommend that the T-score minus 2.5 is taken as a diagnosis of osteoporosis in non-diabetic individuals. But now they say that you can use -2 as a criteria to diagnose osteoporosis in type 2 diabetes, because the patients with type 2 diabetes are having the more high risk of fragility fracture because of the aerodynamic bone disease in patients of type 2 diabetes. And while taking care of the FRAX, you can enter as a instead of rheumatoid arthritis, you can enter rheumatoid arthritis, you can take as a diabetes, and that will give you the score for the hip fracture as well as the spine fracture. If it is beyond that limit, then can be planned for the treatment. So this is
But
that.
Sanjay, these that you can replace rheumatoid by diabetes, is that officially accepted? Or
Yeah,
instead of minus 2.5, minus 2, is that accepted? Does ISBMR, does it tell us so?
yeah. So, sir, actually, ISBMR just they publish their guidelines, but not specially mention about this diabetes like this. But now, say most of the guidelines include that you can consider minus 2.5 to minus 2, and can use the as a risk factor, diabetes as one of the risk factor like rheumatoid arthritis. Yeah.
Right. Okay, good. So once again, Pramila, this Dr. Madhu Bakshi, who asks you after 24 months of teriparatide therapy, what should be given, what should be the ongoing osteoporosis management?
Yeah, I think Dr. Sanjay Barada is there, so he is the expert.
Okay, right. Yeah.
Okay, so I think this is very, very pertinent question, and that after 2 years, so one most important thing I would like to tell our participant audience is that you should not have a gap of more than say 15 days after finishing the teriparatide therapy. And if we will delay, then there is benefit will be, we are going to lose the VMD if we'll take more time between the starting anti-resorptive therapy. So the options are two: anti-resorptive therapy in form of zoledronate and the denosumab. And in patients of type 2 diabetes, if we talk, in that case, denosumab is preferred because denosumab has some anti-hyperglycemic efficacy also. And that is the, but of course, that is one of the issues, that costly drug is costly. But now with some of the Indian companies, especially like Indian pharmas are providing this denosumab, which is very cost effective, you can say, so that you can use the denosumab instead of zoledronate. But people are not willing to denosumab because of cost. They can take help of zoledronate also after the 2 years of the teriparatide therapy. And the denosumab is already having the safety and efficacy for more than 10 years in patients of osteoporosis.
One
Good,
problem
thanks.
we face.
Continue every 6 months, because zoledronate has one more issue related to heart rate and arrhythmia, and the patient with diabetes, cardiovascular disease. So what to do? I mean, denosumab can be continued for a long period of time.
And so one more thing that what patients do is a lot of times they don't continue the denosumab. Like whatever patients who had stopped teriparatide and we offered them denosumab, they may take for a few months and then they stop it 1 or 2 years later. So that becomes a problem. So in that case, what should be our take? Like, should we offer them denosumab? Because this is compliance is a big issue for in the long run with denosumab because of the cost still. Though it is a little bit cheaper with the Indian brand, but compliance is an issue with many of our patients.
Dr. Pramila, I agree with you. And while after finishing the teriparatide therapy of 2 years, I just believe a person who received daily injection for 2 years, I'm sure he will be compliant to the denosumab also. Yeah. But still, you can ask the patient definitely that this is the 6 monthly medication. Are you okay with that? If not, then we can definitely go for zoledronate also. Yeah. Definitely, that's absolutely fine. Yeah.
And the final question is actually from Bansi, because he's been harping that diabetes starts early. So our friend Dr. Dr. Jain has said that vitamin D deficiency is quite high, so we may have more cases of osteoporosis even in younger population in near future. What are your thoughts?
But I was sure that, all the questions will be asked related to osteoporosis, because in India, everybody knows the diabetes. And that itself shows that it's a bigger health problem. So whether participants are 5,000 or 50,000, everybody knows, all physicians across the country. But I fully agree that vitamin D deficiency is again a major challenge. That does not mean that we are going to have, but otherwise also osteoporosis in our country is not just because of vitamin D. They are not doing exercise, sedentary lifestyle, muscles are weak, bones are weak. So an osteoporosis someone is going to develop or not, that is, how he was active in his 20s or in his early age group, that will decide that how early or how late he is going to develop the osteoporosis. Yes, vitamin D status is also very, very important, but all other aspects are equally important.
Right. And sticking to you, Bansi, Dr. Tripathi states diabetes is associated with multiple complications. And so, what is the best approach to screen various complications in type 2 diabetes? I think all the august bodies have laid down the recommendations regarding screening of complications. But Bansi, a quick word on that.
So, I mean, there is as you are saying, that different organizations have talked about it, but what we say that annually screening of the complication is very important. See, in India, there are two major issues. One is 2/3 of diabetic patients are not controlled because they are not monitoring their sugar themselves. That is the first and foremost problem. If you are not monitoring, they feel that my sugar is well or it is okay, I don't have any symptoms. And that is the reason if cross-section study, if done anytime, 70-80% of our patients are not controlled. The second major challenge is people are not screening for the complication. The way diabetes is asymptomatic, the early complication of diabetes are also asymptomatic. So patient will not develop till they develop background retinopathy. They will not develop till they have macroalbuminuria. They may not develop any problem till they have atherosclerosis, unless they go with the myocardial infarction, they have heart failure, they have severe retinopathy, or then they develop any other complication, or their creatinine is becoming very high. So, I mean, every year annual screening program for each and every diabetic patient is must, along with a regular self-monitoring and 3-monthly A1C monitoring is minimal. One should do regularly for all diabetic patients. That should be the part of follow-up.
Thank you. So with these, we move to another very interesting aspect, which will be of interest to practicing physicians as well. Thank you, both the speakers, the protagonist and the antagonist, as well as Professor Sanjay Vadada, for chipping in with your vast knowledge and experience. So we now move over to a slightly different issue, that of nutrition management, which we may not be primarily equipped or best equipped to talk about nutrition. But many times we also need to advise our patients, and we also need to know what is best for our patients. And so something that you see every day, and if I go to anywhere on my smartphone, intermittent fasting keeps on popping up. Intermittent fasting is good. And so really I thought, let's try and have knowledgeable people tell us about the issue of intermittent fasting. How big is it? And so the topic that has been decided is intermittent fasting is clearly superior to small frequent meals for metabolic improvement. Standard small frequent meals is what we have been advising our people with diabetes, but now intermittent fasting has come in a big way. So to speak in favor of the motion, we have Dr. Beatrice Ann, who is associate professor and in charge head of the Department of Endocrinology at Nizam Institute of Medical Sciences in Hyderabad. And to oppose, we have another very young and dynamic endocrinologist of our country, Dr. Suresh Damodaran, who is a consultant endocrinologist and diabetologist in Coimbatore, and is also vice president of our Endocrine Society of India. And after they have had their blows and fights, they can't have fisty fights, they are separated in space. We'll have a final sane voice in the form of Professor Nilanjan Sengupta, who is a very senior endocrinologist. He's professor and head of the Department of Endocrinology at NRS Medical College in Kolkata. So he will be the neutral voice. And of course, we shall try and answer questions that are put in the chat box by our audience. So first, to Dr. Beatrice Ann for speaking in favor of intermittent fasting. Over to you, Beatrice.
Thank you, sir. A very good evening to all of you. In fact, it gives me great pleasure to be doing this debate in the presence of my teachers. And I'll be talking for the motion. So I'm going to be talking for intermittent fasting is clearly superior to small frequent meals for metabolic improvement. So our food habits have evolved over centuries. So we have had our ancestors and the hunter-gatherers the Paleolithic period, where people ate when there was food in abundance and there were periods of starvation. And now we have moved over to a period where food is available at all times. And probably this is one of the reasons what has brought over the pandemic of obesity amongst us. And for this, what is the link? So the link is this, is the time of day dependent patterns of circulating hormone levels. So all the hormones involved in metabolism, to name a few, insulin, ghrelin, leptin, cortisol, FGF21, so all of them have a circadian rhythm. And what are the impacts of food habits on metabolism? So when the feeding habits are misaligned with the circadian clock, so what happens is there's going to be a disruption of the circadian clock, and there is going to be an increase in the risk of metabolic problems. And when the feeding habits are matched with the circadian clock, as in intermittent fasting, time-restricted eating, where the daily eating window is between 8 a.m. to 4 p.m., there is a circadian clock alignment, and there is a decrease in the metabolic risks. So we need to understand the circadian and the peripheral clocks. So the circadian clock, the master biological clock, is in the suprachiasmatic nucleus of the hypothalamus, which responds to the light and dark stimuli. Whereas the peripheral clocks, like liver and the skeletal muscle, the food acts as the cue for the functioning. So as the circadian rhythm synchronizes, like the fasting and time-restricted feeding regimens, which actively impose a diurnal rhythm of food intake, which is aligned with the 24-hour dark light cycle, it leads to improved oscillations in the circadian clock gene expressions. And it also leads to reprogramming of molecular mechanisms of energy metabolism and improved body weight regulation. And the desynchronization, where people eat throughout the day, be it small frequent meals, if the eating happens throughout the day, there is going to be desynchronization of this central and peripheral clocks, and this may lead to an increased risk of chronic illnesses. And before my opponent starts talking to you all about how our patients are going to be kept starving in the intermittent fasting regimens, let me throw some light on the different sort of IF regimens that we have. So we have the complete alternate day fasting. We have the modified fasting regimens, that is a 5:2 diet, where the patient can take food ad libitum on 5 days of the week with 25% of calories on 2 days a week, and time restricted feeding, which is very popular, and this allows ad libitum intake within specific time frames, and this is usually, it needs to be along with the circadian clock, so it should be along with the light dark cycle to have the maximum effects. And of course, we know about the different forms of religious fasting like Ramadan, and wherein we have learned a lot about the metabolic impact of fasting. And what are the metabolic effects of intermittent fasting? So we've had many studies which have looked at the metabolic effects of intermittent fasting. So to sum it up here, there were significant decreases in fasting insulin and fasting glucose, and there were significant improvements in circulating LDL cholesterol and triglycerides in those people who did the intermittent fasting. And there were also significant improvements in inflammatory markers, including CRP, TNF-alpha, adiponectin, leptin, and brain-derived neurotropic factor. And now my opponent is going to be telling you all about how the people are kept hungry, they also get angry, and they have mood disturbances. So some of these studies, in fact, have looked at these as well, and they found that the participants' feelings of fullness and levels of PYY, in fact, increased. And only a small proportion, generally less than 15% of participants, reported negative side effects such as low energy or hunger, which again can persist only up to a month, and the patients get used to it. And however, there were mean improvements in mood, including reductions in tension, anger, fatigue, and increases in self-confidence and positive mood. What about the effect of intermittent fasting on blood glucose? Again, each 3-hour increase in nighttime fasting duration was associated with significantly reduced odds ratio of elevated HbA1c, and also led to a significantly lower CRP concentrations. And what about cancer? So this is the analysis of the nightly fasting interval in breast cancer survivors in the Women's Healthy Eating and Living Study. That's a well study. And they found that cancer survivors who fasted less than 13 hours per night during 7 years of follow-up, they had an increased risk of recurrence. And what about the effect of intermittent fasting on gut microbiota, which again is a very important factor in metabolic diseases? So the gut microbiome also has a circadian rhythm, and that is entrained by food signals. So an extended fasting period, in fact, could lead to reduced gut permeability, and as a result, it can also lead to blunted postprandial endotoxemia. And the very interesting concept of the brain-gut pathway, it gets activated in the brain during fasting. It acts to promote energy balance by enhancing the gut epithelial integrity. And what about the effect of intermittent fasting on lifestyle behaviors? So increasing the nightly fasting duration to more than 14 hours, it resulted in statistically significant decreases in energy intake and weight, as well as improvements in self-reported sleep satisfaction, satiety at bedtime, and energy levels. And most fasting regimens, they do not give too much time for the patient to eat. So that reduces the total number of hours available for eating, and in fact may reduce overall energy intake and risk of obesity. So this is a meta-analysis again, which looked at the effects of time-restricted eating on metabolic diseases. So the effect of time-restricted eating on body weight showed that there was significantly reduced body weight and fat mass in those people who followed the time-restricted eating. And what about the impact on cardiometabolic parameters? Again, time-restricted eating showed beneficial effects on the cardiometabolic parameters such as blood pressure, fasting blood glucose, and cholesterol levels. And this study, again, my opponent may be quoting it. So this is the treat randomized trial, one of the latest and largest RCTs on time-restricted feeding. And this was basically to look at the effect of 16:8-hour time-restricted eating. So 16 hours of fasting with 8 hours of eating. So on weight loss and metabolic risk markers. And this study had two groups. So one was a consistent meal timing group, and who was instructed to eat pre-structured meals per day. And then there was a time-restricted eating group where they were allowed to eat from 12 p.m. until 8 p.m. So the primary outcome here was weight loss, and the secondary measures were metabolic parameters. So this was a weight change which was recorded in the total cohort. There was a significant decrease in the weight in the time-restricted eating group, but there was no significant change in the consistent meal group. And the self-reported adherence to the TRE schedule was also high. And what about the AHA scientific statement, the meal timing and frequency? What are the implications for cardiovascular disease prevention? So we see here that alternate day fasting, that is fasting around 3 to 4 days per week, it brought down changes in the weight. There was a significant decrease in the weight, and there was also improvement in the cardiovascular risk parameters like total cholesterol levels and the blood pressure, glucose, and insulin. And there was also improvement in the HOMA-IR. And periodic fasting, that is fasting 1 to 2 per day per week, again showed improvement in the weight and the CHD risk parameters. So why does this happen? So what happens here is the metabolic switch. So when people fast, there's going to be a metabolic switch, and there is going to be dependence on ketone bodies as the primary fuel. So we know ketone bodies are not only superfuels, but they're also signaling molecules which activate many pathways. For example, there is substrate availability to cause increased ATP production. There is also increase in the mitochondrial biogenesis, increase in the autophagy, and decrease in the mTOR pathway. And this leads to improved performance, stress resistance, and there is also an increase in the brain-derived neurotrophic factor signaling. So which is again going to improve the synaptic plasticity, and it is going to lead to neurogenesis. And in fact, intermittent fasting has been touted as one of the treatment modalities and even for prevention of neurodegenerative diseases. And there are many trials which are underway and on looking at intermittent fasting or the effects of intermittent fasting on cancers. So there are studies on glioblastoma, there are studies on breast cancer, prostate cancer, and so on. So we know here that from all the data that I have presented, intermittent fasting is effective. What about the small frequent meal patterns? So I'll present a few data about the small frequent eating patterns. So what happened, my opponent is going to tell you that the entire day the patient eats, the appetite is going to come down and they're going to be a decrease in the food intake. But what does the study say? So taken together, the findings of the study show that increased eating frequency, that is more than 3 eating occasions per day, has minimal, if any, impact on appetite control and food intake. And this is again another study which had looked at the review which had looked at the effects of a traditional meal pattern versus small frequent meals on body composition in overweight and obese adults. And they showed that there was no significant difference compared to the traditional meal pattern in those people who are following the small frequent meals when it comes to body composition or the BMI. What about, again, we'll go back to the AHA scientific statement where they have looked at the meal frequency and what are the implications for cardiovascular disease prevention. So those people who had 6 meals per day did not show much improvement in the weight. And those people who had 9 meals per day, 12 meals per day, 17 meals per day, again, did not show any improvement in the weight. And what about the risk of CVD? If you look at this box here, people who had more than 6 times a day meal, in fact, were at higher risk of CVD. We look at the odds ratio here, which keeps consistently going up even after adjusting for the confounding factors. So to summarize, small restricting calories by fasting intermittently, it provides extra metabolic health benefits, and we do not have strong positive data regarding the efficacy of frequent small meals on metabolic parameters, and it may even be counterproductive and lead to an increased risk of CVD. And it is difficult to divide daily caloric intake into multiple small parts, and it can lead to overeating, which is most of the time. And it is easier to restrict food intermittently where the person is not allowed to eat. It is easier that way. And time restricted pattern, again, it matches with the circadian pattern. So if you're still wondering whether it is possible in real life about this intermittent fasting, look no further than this island, Okinawa in Japan, where the native population, in fact, follow a regimen of intermittent fasting, and they have been found to have the least incidence of diabetes and metabolic diseases, and they have extreme longevity. So thank you all for patient listening, and thank you for the opportunity.
Thank you, Beatrice. You made a strong point about the benefits of intermittent fasting, possibly related to the biological clock, trying to mimic your biological clock as regards your eating patterns. So we'll now have the opposite view from Dr. Sudesh Damodaran about maybe trying to establish that small frequent meals should be better than intermittent fasting. Yes, Sudesh, floor is yours.
Okay. Good evening, everyone. Thanks very much, Professor Shubhankar Chowdhury, and it's nice to be a speaker under him. Now, thank you for the opportunity, and it is the previous speaker made my job much easier. I think she was quoting almost 6 or 7 times that how the next speaker is going to be coming up with the real facts. So the intermittent fasting is clearly superior. It's not the way that it is going to be the small frequent meals. So before even talking about the science, I want to just tell you there is 2-3 things actually. The pragmatic or the practical way how you're going to deal with this kind of diet. For me, there is 3 things, 3 C's, for example. One is the compliance. Whether it's going to be long lasting, the answer would be no. And whether it produces confusion for the person about the methods of intermittent fasting, answer is possibly yes. And whether there is a confusion for the patient himself after getting into a fasting state and getting into a confusion and irritability. My previous speaker was saying that confusion and the irritability and everything gets much better over the time, but it's like marriage. I think sometimes it may not be you're saying that you have to try to live and it might get better, but that's a hope. So I'll tell you some signs, and I think if you look at the small frequent meals, the increase in frequency makes the lean body mass, and we got evidence to show LDL is decreased, and then it got almost like an incretin effect with delaying gastric emptying, and that causes almost the fullness actually. So if you have a multiple frequent meals, the cholecystokinin and all the gut hormones comes into play, and this has been happening for many years. I think the quoting was a small island from Japan, but if you look at the world-wide Europeans and the people who live in Mediterranean, they are used to habits like a small frequent meal. And we know that the thermic effects of the food, which is like diet-induced thermogenesis, that is almost 60% basal metabolic, 30% activity, and the TEF for each macronutrients is there, but I think the energy takes it to metabolize the food and the heat is produced, but eat a decent amount of food. But I think TEF, what happens is it increases the metabolism and results in the needed to the digestion of food consumed. So the key is very small meals with a strong consideration of macronutrients is the way forward. What is the evidence for it? These are all the pooled data of the RCTs over the years from 2012 to until now. And you can see I won't go into the details of each and every study, but the BMI, the lean body mass, and the total body fat all comes down with amount of frequency of meals. So you can see here where the frequency goes from almost 6, the head-to-head data showed the multiple frequency meal is the one which produces the BMI reduction, lean body mass formation, and also the fat mass decreasing. So this is like a pooled observational studies over the years from 1960. So you can see again the multiple frequent meals is the one that produces almost like a negative correlation between eating frequency and body weight. So if you eat more frequently, the body weight observed in male, of course you have to look at the calories what you eat, but I think it is inversely proportional, and if you adjust to the sex and the physical activity and everything, still there is a lower risk of developing obesity in those people who are eating more frequently. So hope you understand with the studies of RCTs I've showed you and also the observational studies, it is clearly evident that not only the BMI, lean body mass, but the weight and also other metabolic parameters increase significantly. So this is one of the data my colleague has shown as well, but I think if you see from 1994 and 1989, this page, this slide shows 1 meal per day data, and that is showing in the right-hand side with CHD risk parameters. There is not much of significant benefit. So if you go to the next slide, which is 6 meals per day, which shows significant benefit in the total cholesterol and also the bad cholesterol like LDL, and then there's some improvement in HDL as well, which is a real bonus when you do get it. And this is published in Circulation in 2017. So again, just to show when you go for a more frequent, like a 9 meals per day, there is the benefit is still there. So the summary is when you have 1 meal, the cardiovascular and CHD risk parameters are not that beneficial. But if you go for a 6 or 9 frequent meals, counting your calories, then there should be a benefit with the CHD parameters. So this is the thing in the second or third slide of my colleague shown. There are quite a lot of different types of intermittent fasting. And I think the definition itself is not clear. We are talking about a wide area of different types of fasting, time restricted, once a week, alternate days, and you're showing a data for one thing, and then you wanting the people to understand that the intermittent fasting is the new sort of gospel sort of thing, and it is not true actually. So it is very, very confusing, and there is energy restriction and twice a week. I mean, what is that? I think people get confused. So people might think, I think it might be just between the meals, you know. So this is another data my colleague has shown with the 19 studies with the meta-analysis data. So she showed the benefits of the body weight compared to the baseline, but there is only one study which showed the significant overall positive effects. And how can we consider this is a beneficial effect in this meta-analysis? It is not at all beneficial. I think she showed this data in a nutrients study of 2020, but it shows how can we consider this is a beneficial effect when there is heterogeneity, which is slightly in the higher side. So this is the paramount importance, leave alone the fact that what is there as a definition and what is the confusion about the definition and what is the evidence which is there. But the safety of the intermittent fasting, now that energy restricted period, definitely they don't feel good, and non-energy restricted period also not feeling good. It is it is a full lockdown or a partial lockdown in COVID, there is no feeling good factor there. So feeling cold, tiredness, she mentioned about the irritability, but the lack of concentration is definitely there. I mean, you and me know when we are hungry and everything, how irritable we can be. Leave alone that the long-lasting fasting, people just feeling cold, tiredness, excess loss of energy, and then dizziness will comes in, cramps in the leg, you name it. So there are quite a lot of troublesome things. So no one select the troublesome option, definitely not. And if you do that, I think you have to explain every time that that you are in hunger, and you have to just carry a board of some sort that you're in intermittent fasting, because the lifestyle might get changed and your daily life can get affected, your relationship can get affected, there might be multiple thoughts. Leave alone all that, but if in a diabetic, what a big mistake if you're going on that. It's just the hypoglycemia risk is so high, and also during the fasting days, in individual, if you don't reduce the medicine, then there is a big challenge. But if you do the reduction of medicine on fasting days, if there is a less than 400 calories, then the possible hypoglycemic mechanism. So firstly, I mentioned about 3 C's. One of them is the compliance. So anything what you start in life, I can see in, at least in the region where I live in, a new diet started, and then even almost restaurants were opened. But I think it was not almost, it was given away because people are not following it. So the compliance, so whatever we follow at certain age or following as a procedure or a lifestyle, it has to be compliant. And I think intermittent fasting cannot be sustained, and it's almost like 20%. So what about non-fasting days? So you're saying the non-fasting says super good, but I think it works by creating a calorie deficit, though the periods of fasting than few. So people will be feeling awful even the non-fasting days, but it will be only be successful if you eat relatively normally on non-fasting days. You can't eat too much on that. So effectiveness of intermittent fasting and time restricted feeding compared to the continuous energy restriction. So if you do a continuous energy restriction, is it much better compared to a time restricted thing? If you look at it, the last area, it shows that overall available suggests that both intermittent and also the continuous one, so out of the 9 out of the study shows no difference between these two groups. So you don't need to be doing an intermittent fasting. So it just cannot be assumed as a weight loss program, but as a detox or a regeneration or something like that, and longevity extended process. So we think that intermittent fasting is a new diet trend. No, I think our lifestyle, a lot of people are like this. We are doing it, but that doesn't mean they are getting benefit out of it. So the latest and largest RCT, my colleague was mentioned, to determine the effect of 16 and 8-hour time restricted eating on weight loss and metabolic markers, and there is no there was a significant decrease in weight with the intermittent fasting area, but I think there is no significant changes in the secondary outcomes between these groups. So skipping a meal is harmful, definitely, compared with the man who eat 3 meals a day, ate 1-2 times a day, that there is hazard ratio for diabetes mellitus is 1.26 of adjustment, and also that is even if you try to alter for BMI, but there is in contrast, if you eat frequently, the diabetes risk is less. So this itself says it is harmful, don't go there. So big picture is big no to intermittent fasting. So unless you got other reasons, like if you forget your groceries, for example, you can tell your family that you go around fasting, and there are other reasons to become fasting. So just to summarize, increasing meal frequency appears to be an excellent method where there is delay in gastric emptying, decreased satiety, works like an incretin, and also there is much more to it. It is just a cardiovascular profile, improves particularly the LDL cholesterol, total cholesterol, and insulin, by restricting calories, it doesn't provide an extra health benefit at all. And I've showed you about the diabetes and also other benefits. And if you look at Asians and Indians, for example, we eat a lot of spicy food. And if you're starving yourself, you really get into trouble. Most of us already had GI symptoms, but I think the fasting in an Asian could be disaster with other health benefits as well. And difficult to follow, and it can't be sustainable. It's not sustainable with many adverse effects. So my conclusion is, I think small frequent meal is much better alternative than the restricted one. If you are looking for immediate benefits, probably short time you can do, but it can't be much beneficial in the long time. And if you make our patients starve or give us a prescription, they won't like you after some time. They'll try to find probably a different doctor. And anyway, just to summarize, this is eat a small frequent meals and also combine with a low glycemic food. Aim to have a half plate of vegetables, take a short walk, and these are all the recipes. Thank you for that.
Thank you, Suresh. I think the main planks of his arguments were, one, that compliance could be an issue with intermittent fasting, and two, it may be associated with better weight maintenance or weight loss, but eventually what also matters is cardiovascular risk factors. So of course, we didn't talk of cardiovascular events, we didn't go up to that, but at least the risk factors possibly are not so favorably influenced. So a couple of minutes to Beatrice for her rebuttal.
Yes, we have presented actually both sides of the picture, like for both the types of dieting. But whatever the diet is, what makes the diet successful is the adherence to the diet. So how feasible or how practically possible is it for somebody to have small, frequent meals? So we live in a fast world, and my opponent himself, being a busy practitioner, I'm sure is missing 1 or 2 meals a day. So, and there's enough evidence to
no. Top priority is eating.
There's enough evidence to show that, small frequent meals may not be sustainable, and in fact may lead to overeating in the process. And the studies that have been quoted by my opponent, they are not long-term studies, and many of the studies were done in controlled settings. And these cannot be extrapolated to real life settings, where some of the studies, in fact, have been done in real life settings, and the limitations of the study were exactly the problem that we face with small frequent meals. That is, the patients either underreport or overreport their calorie intake. So we have enough scientific evidence to show that intermittent fasting acts on metabolic risk factors.
Right, thank you. So we will now have opinion, final comments, the neutral voice of Professor Nilanjan Sengupta.
You have to unmute, sir. Professor, you have to unmute again. Yeah, now.
Yeah, I think the host has unmuted me. Am I audible?
You are.
Let me share my screen. I have a small presentation.
And while Nilanjan gets ready with his presentation, let me just share that the reason I took or wanted this topic to be discussed basically is for me to learn from it. Because there is so much of hype about intermittent fasting. I hope Nilanjan will finally let me know what I should follow for my patients.
Thank you, sir, for giving me this challenge of being the neutral voice to the excellent debate by Suresh and Beatrice. Well, to me, time-restricted eating or intermittent fasting, whatever you call, is now a novel nutritional concept, and which has been aptly defined by Beatrice. But having said that, in some form, this is practiced by many ascetics. Beatrice had taken us to a Japanese island, but I think we can just go to the Himalayas, and we have the Himalayan ascetics who practice it, who have been practicing it for years, for ages, centuries, and is also common in the animal kingdom, and is maybe a part of any healthy eating program. What Suresh has said, by intermittent fasting, we are actually clubbing many things. The definitions are not uniform, so we cannot extrapolate data with one others. And these are the host of benefits at the cellular and molecular and also the clinical level, both in rodent studies, in the Drosophila and in human beings, that has been aptly summarized by Beatrice to buttress her points. I do not disagree them on a basic fundamental ground, on a basic fundamental platform. But then there are disadvantages which Suresh has pointed out. First, the lack of uniform protocol, which I've alluded to. Whether this intermittent fasting is physiological or not can be debated, but it is definitely something outlandish to the present day free living humans. Why? A reason why this should be met with a 20% compliance. I think 20% compliance is also something more in the long term. And it is therefore not sustainable in the long run. Then the risk of hypoglycemia would be there in patients of diabetes who are on pharmacotherapy, and that may necessitate some changes in the antidiabetic therapy on the fasting days if alternate day fasting is followed, which would be very disturbing. We know what happens to patients who are on hemodialysis. They land into hypoglycemia. Definitely that would be unsuitable in pregnant ladies and with certain comorbidities, as for example, with chronic duodenal ulcer. Hunger pangs are definitely not something desirable, and excessive satiety on feeding days also can be equally discomforting. And as Suresh has pointed out, in 9 out of 11 studies, there was equivalent weight loss with intermittent fasting as compared to chronic energy restriction. So we are taking so much pains, and the end result is an equivalent weight loss, not a superior weight loss. Of course, Beatrice has quoted one study which have shown greater improvement in insulin sensitivity, better lipid profile, and better, more favorable cytokine profile with intermittent fasting. That would be a food for thought. But again, another study have not failed to show any superior weight loss with alternate day fasting as compared to the standard conventional calorie restricted diet. Now, by standard conventional calorie restricted diet, I do not imply 6 to 9 meals a day, which Suresh has pointed out. I would be happy with a standard in a non-pregnant adult with a standard 3-meal, 2-snack pattern that we are following. So my take home is that ideal animal, including human diet, should be one which consists of optimal energy consumption, which may translate to chronic energy restriction to many humans with some amount of time restricted diet. Because if we are actually not allowing the patient to take any meal after supper to breakfast, that is in some form of a time restricted diet. In cardiometabolic practice, therefore, it is the chronic energy restriction, a rational one, is to be encouraged as a therapeutic approach at the present moment over this TRE or time restricted energy intake till we get even more data with clinical researches. Not, I mean to say, not with animal studies, but further clinical researches are needed. But time-restricted eating or time-restricted feeding superimposed on chronic energy restriction may be advised, may be considered in consultation with certain subjects in certain selected clinical scenarios, which also Suresh has pointed out, in otherwise very motivated, healthy individuals, not at extremes of age, who are motivated for long-term adherence and who are not vulnerable to hypoglycemia. I would thank both Suresh and Beatrice for dealing with the topic in an excellent fashion. And I end with this koala, who you know is one of the best examples of following time-restricted feeding, because the koala sleeps 20 hours a day, wakes up for 4 hours at night to eat some eucalyptus leaves, and they have a lifespan of around 14 to 15 years, which can be equated to around 90 to 100 years to a human being. Thank you. Over to Sir.
Thank you, Nilanjan. So I thought during your presentation, you were heavily in favor of Suresh, maybe because he holds an important position in Endocrine Society. He's the vice president, maybe because of that. But finally, you said that the koala will, like the koala, if you follow a time-restricted eating, then you live 90 years and hopefully productive, healthy, like 90 years. So what do we get from it? I mean, you are being politically correct?
I managed to confuse our audience.
It should be a healthy koala, sir. It can't be pregnant koala, or it can't be any other koala.
Yes. Yes. So as I said, I am still a little bit confused, but and trying to sort of form my own opinion as well.
So this is a successful debate.
This is a successful debate. This is a successful debate. What I personally feel, if you've got diabetes, especially if you're on hypoglycemic agents, following a time-restricted feeding pattern could be much more challenging. It's not that you cannot overcome the challenges, but you can, but it's much more difficult. But in those who are not yet diabetes or not yet on hypoglycemic agents, possibly time-restricted feeding pattern could be implemented and hopefully will have its advantages. Now, we have a few questions in our chat box. So Dr. Jain, so Dr. Tripathi, we go to Dr. Ahuja. Yeah, very important question. So there are so many diet plans, DASH diet, Mediterranean diet, vegan diet, Atkins diet, so on and so forth. Do we need fasting additionally to these diet patterns? So would Beatrice, Mediterranean diets, wonderful diet. So do you also need to fast?
Sir, I will just combine what Dr. Nilanjan had told us. So it's continuous restriction, that is restriction of food combined with following the circadian rhythm is what should be followed. So it should be a combination of both. It's not like the time that you're eating, you go and binge on everything. So you follow a healthy pattern, and at the same time, you also respect the circadian rhythm so that there is no desynchronization as such. And I feel the most important factor in any diet to be successful is patient's acceptance and compliance and long-term adherence.
Right, and that takes us back to both Dr. Suresh and Dr. Nilanjan, who did point out that when we talk of intermittent fasting, it's not just intermittent fasting on a diurnal basis. What you said, what's commonly touted is also maybe 2 days in a week or something like that. So how does that correlate with the diurnal rhythm, the biological clock? If you're fasting maybe 2 days in a week, how does it matter? The biological clock will run its own way, even on the days that you fast totally.
Yes, sir, that may not be totally in relation to the biological clock. Here it is more of the calorie intake. So what the studies have shown that even on the days that they eat, people are not able to make up for the calorie loss which is happening on the fasting days. So that is the concept of the 5:2, which is probably more acceptable to a fewer patients.
Right. And Dr. Riaz, a very pertinent question. I think calorie restriction is more important for weight reduction. Whatever way you can achieve it, it is true. But at the same time, I must say that there is something called chronobiology. Your mitochondria are active at certain parts of the day. For example, maybe the uncoupling protein. So if you tie that to the time of food intake, I think even on an equal calorie diet, taking it differently, maybe at certain times of the day only, could give you better advantages, even in terms of weight loss. It is what my reading of this topic has been. Anyone wants to rejoin into that? Add something?
So may I say? Yeah.
Yes.
Yeah. Actually, I was going through the literature in animal studies or also in some human studies. That is the basic premise of many of the intermittent fasting regimen derived studies. But then we need to have larger studies to say whether that translates into real clinical benefit. And as you have rightly pointed out, intermittent fasting on a diurnal basis can be justified on the chronobiology more than on a total fasting for 2 days of a week and eating on the rest 5 days. To me, that appears less scientific. If at all we have to go for some sort of intermittent fasting, that should be on a diurnal basis, maybe which we are in any way following. Maybe we can increase the time period of fasting.
And that takes us back to your Himalayan, the ascetics, the sages. And however, at the same time, if you look at the Ramadan time, that's also a form of time-restricted eating, intermittent fasting. However, various studies have shown at the end of Ramadan, actually people do not lose weight. They tend to gain
weight. They tend to gain
so,
weight.
So still remains a complicated issue, and we will wind up soon. And so since I can still see Sanjay Varada there, though, who is switched off his video, and Dr. Pramila Kalra. So you are also welcome to join and add to the knowledge base. So Dr. Riaz.
Pramila is in my team, sir. So
sorry?
Pramila is in my team. So I spoke to her already.
What team? What team? We are all on a learning process.
No, I'm just joking. It's supposed to be.
I don't know whether you may have paid her something or whatever.
Yeah.
Right. So Dr. Riaz would want to know what many people eventually will not be able to lose weight. So when do you advise? Oh no, this is from Dr. Agarwal. When do you advise bariatric surgery? Would Dr. Pramila want to answer if she's still around?
Yes, I'm there, sir. So bariatric surgery, what we have to first understand is
your Ramaya Hospital does a fair bit of bariatrics.
Yeah, we do sir, bariatric surgeries.
Right.
But we also have to understand that we cannot just offer it for everyone. So first of all, obviously there are lots of, now even if we talk about diabetes and obesity, we know that there are so many drugs we have like SGLT2 inhibitors and GLP-1 analogs, which we have seen very good benefits in our diabetic patients as regards to the weight loss if we talk about. And also, like, obviously I agree with both points of view. We have benefits of intermittent fasting also, because we have patients whom we have put on intermittent fasting.
Now we have a direct question from Dr. Agarwal. What is the right time to refer patients for bariatric surgery?
So bariatric surgery is like when the patient has not been able to, like patient is morbidly obese, then the point of time comes when we offer the patient to go for bariatric surgery. So bariatric surgery is like, what we are talking at the moment is the benefit of diet, various diet versus drugs in diabetes. But over a period of time, if we have a patient who is diabetic, who is morbidly obese, then we can refer for bariatric surgery. And then we have multiple benefits, but we have multiple issues also after bariatric surgery. It's not so simple that we just refer a patient for bariatric surgery, because now we also have few patients who are coming with post-bariatric surgery complications. So it's like we have to see the balance, and then we have to decide which type of surgery we are offering for, like sleeve gastrectomy versus Roux-en-Y, and all these options have to be discussed.
Is it something that you can dictate your bariatric surgery colleague which surgery he or she should do?
So we discuss with the patient, like whether when the patient has morbid obesity, we take a call, because patient discussion is very important. A Roux-en-Y is a major surgery. So we have to do the discussion with the patient and with the bariatric surgeon, and then take a call. Like if the patient has morbid obesity, severe obesity, more than 40 or more than 35, then, and with high risk comorbid conditions, then we take a call on that.
Right. Suresh, you wanted to say something?
No, I just want to add upon maybe I think the super obesity area. I work with the bariatric team, but the super obesity areas, there is no doubt about it. They should go for a bariatric procedure. But even the mild and moderate ones, I refer mainly with the comorbidities, people with the terrible sleep apneas, arthritis, and bad diabetes, and I think is on multiple drug regime, and their quality of life is affected. Those kind of people will get more benefit. But Dr. Shubhankar Chowdhury's question is whether can you control our surgeons, whether they can do this thing. Probably not. It is like having an adenocarcinoma or a thyroid lump or something. We cannot control our surgeons.
Fine, thanks. So,
but we still try to have a discussion with the board. Like we have a sort of a group, and where we discuss, and we discuss with the patient also, because sleeve versus Roux-en-Y, we have to discuss the post-op things also.
So that's the ideal thing to do. You have the surgeon on board as well. Yeah, that's great. So finally, we'll wind up with Dr. Riaz's question or comment, that something maybe that I've already mentioned. That for those who have got diabetes, maybe small frequent meal platter is more applicable, and for non-diabetic obese, maybe intermittent fasting may have a bigger role.
Provided that normal person going into intermittent fasting should follow it. The compliance is there.
Yes, absolutely. Compliance is always a big issue. So with these few words, I would like to thank each one of you this evening who joined in, and I hope we could get our points across to a wide range of physicians across the country. Usually I get a number. I'm trying to see how many joined. I can't see it today, but usually it's upwards of 1,000 physicians who join, and I'm sure they'll be able to implement this in their clinical practice as well. Thank you very much. Have a very good evening, all of you.
Sir. Thank you. Thanks, everybody.
And thanks for our audience. And for those excellent questions that they have put. Thank you very much.
So,
thanks, Professor.
Thank you, sir. Thank you very much.
Yes, now it's over to Intas.
Yeah, thank you, sir. Thank you very much. My sincere thanks to you, sir, to our course director, Professor Shubhankar Chowdhury, for patronizing this program since its very beginning. And we have already done 16 editions earlier, and from the last month, we designed in the form of Endocrine talk show. It has been very well appreciated. And today also, sir, as we have been joined by more than 1,000 doctors from all across the country. So thank you, sir, for continuously improvising the program, making it more exciting and appealing to the audience. And I would also like to thank all the faculty who have joined in from various parts of the country. So thank you, Dr. Pramila Kalra. Thank you, Dr. Bansi Sabo, sir, Dr. Sanjay Batata, Dr. Beatrice, Dr. Suresh Damodaran, sir, and Dr. Niranjan Sen Gupta, sir. I think today's debate has been really very exciting. I think it will sort of refresh the approach of the clinician in treating these kind of patients. I'm sure you enjoyed being here as we enjoyed having you all here. I would also like to thank all the clinicians who have joined from the country, various part of the country. I think there are more than 1,000 who joined in from various parts. I think they must have had their time well spent in attending this program. And once again, we would see you all in our next month's edition of Endocrine Talk Show. Since then, good night and goodbye to all of you. Have a nice evening and a weekend. Thank you.
Thank you. Thank you.
Thank you.
Thank you. Good night, everyone.
Thank you. Thank you.